Okay, dear colleagues, people are dripping in, but I think we should start. 11 o'clock was the time that we should start, so I think we'll get heading off. Perhaps there'll be more people dripping in, because it is quite intimidating. I'm just the chair, but I think for the speakers to be in a big audience, they don't know whether to expect, people are expecting them to sing or present, but they will be presenting there. And I welcome you to this session. A roadmap for digital therapeutics, diabetes and pharmacy, and a promise of digital tools in practice. I think we have two excellent speakers who will lead you through the topics. I'll introduce them separately when we get through the program, which will start off with Elise giving her lecture, and then Mara Santos will be presenting the second lecture. But of course, first we have to go through some logistics. There is the conflict of interest, and there are no conflicts of interest of either speaker, I believe. No. And make sure that you evaluate this session through the FIP Congress app, and which, if you haven't downloaded by now, I don't think you will be downloading it, but at least I hope you have downloaded it, and please do evaluate the session. The questions, please keep your questions until after both presentations, because we'll have a Q&A panel session at the end where you're very free to have discussions, and I really do encourage you to think about other ways of listening to the presentations and get inspired and inspire the speakers back so we can have nice conversations. There will be some questions asked, and you have your yes and no answers. No recordings are to be made of the sessions, but you will get the slides, the PDF of the slides soon after the Congress, so there's no reason to record anything. I don't know why they say this, but you may not download the speaker slides. I wouldn't have a clue how to download them, but it is not allowed anyway. But we will email the link to the online presentations after the Congress. Do tweet and share. I still call tweeting, but don't do X and share, please. And use the hashtags at FIP Congress or hashtag FIP 2023. And please do turn off your phones or put them into silent mode. At the end of the Congress, most important, please do take your belongings when you are leaving the room. And come and visit the FIP booth, the last chance today, and learn more about FIP and its programs. The session does give credits to those eligible to a CPD system, and by now I think you're all aware that it is all these different organizations that provide CPD points, and you have to register, and you have to give answer a survey, and then you will be registered for the points. If you are eligible there, it is important to remember the code of this session, which is 2142. We will repeat it at the end of the session too. So, happy Pharmacy Week. It started off with the Pharmacy Day. Now we're having a happy Pharmacy Week, and it's great having you all here celebrating it together. But let's get on with the presentation. And the first presentation, somebody's moving my slide here, something here. The first presentation is by Elise Griffith, and Elise graduated from Monash University as a pharmacist, but also got her master's degree in public health at Monash University. And Elise did her internship at the Royal Melbourne Hospital, and then stayed on there as a hospital pharmacist in a medications guidelines role. In this role, she helped create a common formulary for several hospitals in the Melbourne region. Then she became the lead analyst for pharmacy and medications team when they were rolling out EPIC, the electronic health medical record, into the Royal Melbourne Hospital, together with the Royal Women's Hospital and the Peter MacCallum Cancer Centre. Once the project was live, Elise couldn't sit still and she wanted another challenge, so she moved to Canberra, and she has been the lead analyst for pharmacy and medications team in the implementation of the EPIC digital health record at the ACT Health. The digital health record went live in November 2022, and along the way, Elise gained experience with Omnicell and Pyxis automated dispensing cabinets, as well as Merlin and Merlin app dispensing software. Then one thing, and Elise told me to make sure she is very passionate about medication and medication safety and clinical efficiency. So I'm sure you'll get that throughout the presentation, and I hope you enjoy it. So Elise, please may I ask you up from the stage.
Thank you very much, Rob. So, there we go. I don't have any conflicts of interest to declare, but I should warn you that in the title it says something about providing you with a roadmap, and I use GPS everywhere I go, so I'm not sure that I am the most well-qualified person to give you this presentation, but I will do my best and hang in there with me. So today we're going to talk about why diabetes needs our attention, and then run through some benefits and considerations around electronic health records, telehealth, mobile health, smart insulin pens, continuous blood glucose monitors, and we'll briefly touch on artificial intelligence. So why should we focus on diabetes? Firstly, the prevalence. 8.8% of the world's population was reported to have diabetes in 2017, and this is projected to rise to 10% of the world's population by 2045. Closer to home, it's estimated that about 5.3% of Australians have diabetes, but that ranges up to 15.3% in US population. So this is a big problem. Secondly, our quality of life. Diabetes and its complications can have a significant impact on quality of life and is a major cause of blindness, heart attacks, stroke, kidney failure, and lower limb amputation. It's also associated with a high prevalence of depression and adversely impacts employment and absenteeism. Thirdly, mortality. Diabetes was the 7th leading cause of death in Australia in 2020. And in the year before, diabetes was the direct cause of 1.5 million deaths globally. Over the last 2 decades, the mortality rate of diabetes has increased, whereas the mortality rate for other main non-communicable diseases has decreased. And lastly, cost. 10% of global health expenditure is on diabetes, with estimates ranging from 760 to 825 billion US dollars, which means that more resources are spent on diabetes than almost any other health condition. Before delving into discussing electronic health records, I thought I should provide a little bit of context of where I'm coming from. As Rob kindly mentioned, I'm the lead pharmacist for the medications and pharmacy team in the capital of Australia, which is Canberra, represented by the red star on the map that you see. Whereas we are currently in Brisbane, the Blue Cross. Hopefully your jet lag has sort of recovered enough that you know where you are and that makes sense. The Australian Capital Territory, or ACT, has a population of 454,000 people. Almost a year ago, we implemented a territory-wide electronic health record across all of the public health services in ACT. These include our 3 public hospitals, our mental health centre, an Aboriginal health centre, 5 walk-in centres, and also our justice health system. In recent-ish stats, we now have over 211,000 patients signed up to our patient portal, which is part of our electronic health record. So one of the most useful things that we can do is to capture and store data discreetly. This allows us to more easily compare trends over time and also leverage decision support. When a low blood glucose level is recorded, we can trigger a warning and say, hey, that's low, and here's what you should do about it to standardise to best practice. Storing photos of feet and ulcers can also be incredibly helpful, and we saw mentions of that this morning in Dr. Bain's presentation. It means that we can have an objective point of comparison to identify when an ulcer has deteriorated since the last review. It's also easier for other staff who may be working remotely to escalate care to a doctor when they're concerned, which can improve quality of life by enabling earlier intervention and specialist care when required. The ability to have reminders in a digital system is also invaluable. For example, it's been 12 months since your last referral to an ophthalmologist or an endocrinologist or a diabetes educator. And I also wanted to touch on prioritisation. This is a screenshot. Oh, it does work. This is a screenshot of a tool that our pharmacists can use in the hospital setting in ACT. Various conditions and medications are assigned a score. A diagnosis of diabetes or taking insulin prior to admission to hospital combines to increase the patient's score. And a higher total score means that a patient is more warranting a clinical review from a pharmacist earlier. Once a patient has been marked as reviewed, the score will continue to automatically recalculate, and that change in score can be another indication of when a pharmacist should review the patient. I mentioned the benefits of discrete data just a moment ago. This is another screenshot of a tool that is used to facilitate glucose management for our hospital pharmacists and other clinicians during a patient's stay. It shows their blood glucose level over time, along with corresponding anti-hyperglycemic medication administrations, whether the patient has had any other administrations that might be relevant for their glucose management, such as potassium or corticosteroids, as well as their dietary intake. Other observations or relevant pathology can also be displayed where available, such as ketones or HbA1c. This method of presenting the data can help to see many interrelated factors in one screen and how they are changing over time. It saves the clinician time from hunting in the chart, looking for the information that they need to take care of the patient, and minimises the risk of overlooking relevant data. Now let's talk about telehealth, which is healthcare provided remotely via an audio-visual technology. In general, an increased frequency of patient-physician encounters, or better adherence to scheduled appointments, were associated with earlier and more sustained achievement of targets for HbA1c, blood pressure, and cholesterol compared to less frequent interactions. Fortunately, in another study where they compared mixed in-person and telehealth visits to the same frequency of solely in-person visits, it was found that there was no difference between HbA1c, blood pressure, or lipid levels for patients with diabetes. And there was a significantly greater reduction in mean body weight for the telehealth visits group. And a meta-analysis of studies found that a greater reduction in HbA1c for patients enrolled in a telehealth program. So telehealth has some positive evidence for patients with diabetes, as well as several other benefits. These include reduced travel time and costs, such as parking, when needing to interact with a healthcare professional, reduced time away from your usual activities, and reduced total clinician time for the time that they spend seeing the same number of patients. And it also has a high patient satisfaction level. It also provides a convenient method of delivering and receiving group education. And patients in monthly sessions in a group education environment for 12 months had a lower HbA1c level compared to those who were not enrolled, as well as cholesterol levels. There are a few considerations to note. A reasonable internet connection is required, otherwise it seems that your patients have started to develop a stutter when that's not really true. Other technology challenges can also occur, particularly when first becoming familiar with the process. And there may be some circumstances where being physically present could be helpful or indeed required, such as needing a physical examination. So it may not suit all occasions, and that was acknowledged in this morning's presentation as well. I came across this interesting study by Taylor et al. Looking at diabetic retinopathy through the use of tele-DR. And tele-DR is when an image is taken of the back of your eye and electronically sent through to an ophthalmologist for their interpretation. We know that improved screening of diabetic retinopathy is associated with decreased rates of vision loss and blindness. In this study, where nearly 500 patients were given the choice of tele-DR or in-person screening with an ophthalmologist elsewhere, the 40% that chose tele-DR all had their screening completed in that same appointment where they were seeing a nurse for something else. For the rest of the patients that chose in-person screening with an ophthalmologist, they were booked into the next available appointment, which was in a 3-month period. Most of the patients that said that they wanted their in-person screening done with an ophthalmologist did not actually attend that appointment though, and therefore missed or further delayed their diabetic retinopathy screening. I now want to look at mobile health, which is the use of mobile technology to deliver real-time health and metabolic information. And just take note of this photo because I'll refer back to it in just a moment. Text messages can be useful as a helpful reminder for agreed goals and education in between visits with a healthcare professional. When used as interventions on education and blood glucose level monitoring, they are associated with a reduction in HbA1c, and patients also reported improved dietary, foot care, and blood glucose level monitoring practices. Text message reminders to pick up prescriptions and instructions for use in the patient's native language has also been shown to improve medication adherence. There is a high and growing mobile phone use, even in lower socioeconomic areas. This means it's potentially an intervention that may reach a reasonable proportion of your patient population, but likely not all. Messages can also be automatically generated and sent, which means it could be low cost. However, earlier I showed that photo of a Telstra tower in Canberra, where in the capital of Australia, we still don't have consistent mobile phone coverage. And there are many, many more remote areas of the world where this would be a problem too. And now, building on that idea of mobile health, I want to talk about smartphone applications, or apps, which are software designed to be used on a mobile device, such as a phone or tablet. Now, I have to tell you, I really struggled to find out accurate and up-to-date information on how widespread the use of smartphones are across the globe. So I thought we could just work out the answer together here now. Could you please raise your hand if you have a smartphone? Okay, excellent. So that's about 100% from what I can see in this lighting. So it's great to have up-to-date statistics. Thank you so much. In all seriousness, there are various estimates that put the number of smartphones out there between half to roughly 2/3 of the global population. And I don't know how many of those are toddlers. However, it's important to remember that not everyone has a smartphone. And as was mentioned in an earlier presentation this week, some people may have a smartphone but may not be able to afford unlimited data, and so they may be very cautious about how they use their smartphone. There are ever-increasing numbers of smartphone applications or apps available. These can be used by patients to document blood pressure, weight, blood glucose monitoring, nutritional intake, activity levels, as well as accessing educational content. Use of a smartphone app to schedule medication reminders and set personal goals for the person, as well as viewing those sort of data statistics, was associated with a reduction in HbA1c compared to standard care. And this was echoed in the findings of a meta-analysis I've listed on the screen, along with a reduction in weight for patients with diabetes that use these type of smartphone apps, though it wasn't great, not huge, I mean. I mentioned earlier that the Canberra's electronic health record has over 211,000 patients signed up to our patient portal. One of the reasons that we had relatively good uptake, though, that it was a way that patients could book their appointment for a COVID vaccination in our mass vaccination centres during the COVID pandemic. Now, though, patients continue to use it to book outpatient appointments or vary the times that they need it, and to respond to patient questionnaires prior to an appointment to make the best use of their time with the clinician. The benefits of the smartphone apps include the patient being able to set and remind themselves of those goals between the healthcare meetings with a professional. But we also know that there are many lifestyle factors that affect the development and progression of complications from diabetes. So increasing access to and long-term engagement with intensive lifestyle modifications for comparatively low cost can be helpful. In addition, depending on the app in question, it can be that single interface for monitoring, education, access to pathology test results, and communication with their healthcare professionals. We heard earlier from Dr. Claudia Ricken speak about the blending of pharmacy care and pharmacists helping patients to use appropriate apps and answering questions that an app is not able to use. And however much we may wish it to be otherwise, those phones are typically accessible 24 hours a day, including when some people are in the bathroom. Now, some considerations. I know that this has been touched on in earlier presentations throughout the Congress too, so I won't dwell too much. But while there are some promising results, overall there is quite limited quantity and quality of studies that focus on smartphone apps. It's also quite a difficult area to study too, as apps tend to change over time, so with improvements or upgrades or bug fixes. So from the initial trial conception to when a trial's actually published, it might be quite different looking to how it started. Of those with evidence of effectiveness, some find large improvements in HbA1c, others just small. Some find large improvements in BMI and waist circumference and weight, others low to no improvements. This makes it really difficult for healthcare professionals to know which apps to recommend. And a study by Chavez found that the 89 most popular English language diabetes related applications had poor to acceptable rating of information and overall app quality score. And we particularly need to be cautious about any apps that make a recommendation to a patient and ensure that we are aware of the patient population that it was designed for, whether it was type 1 or type 2, pregnant or elderly patients. I'd now like to discuss the smart insulin pens, which are reusable pens that can connect with a smartphone app. So smart insulin pens can calculate doses based on a combination of blood glucose levels, carbohydrate amounts, and settings from the healthcare professional. They can also send a reminder to a patient of when their next dose is due based on the timing of their last dose. And impressively, they can also send a notification of when the insulin in the pen has expired and needs to be replaced, or when the pen's been exposed to temperatures that mean it's unacceptable for use. Currently, there are also only a small number of studies that have been reviewed in this area with clinical outcomes. One study reported improved insulin adherence through a reduction in the number of missed bolus doses, better dosing around meal times, and overall increased time in the desired range or glycemic range that we're aiming for. And this was in a patient population of those with type 1 diabetes who were using it in sort of a real-world setting. However, a literature review found no significant differences compared to non-smart insulin devices and smart ones, but did acknowledge that it might be helpful for some more specific patient populations, such as perhaps the elderly. These smart insulin pens can deliver half-unit doses and can provide visibility of calculated insulin on board. They can also be useful for the healthcare professional, as a patient can send their data through, which includes missed doses, as well as how much the patient actually did get and the timing of those doses in relation to their meals. And it can better indicate non-adherence, because non-adherence to diabetes drugs may range from 53 to 65%. Smart insulin pens were also noted to be preferred by patients to the non-smart options, at least in part because of that increased confidence in not missing doses. And now continuous blood glucose monitors, which are devices that are inserted just under the skin and have Bluetooth capability, so that a blood glucose level can be sent through to a smartphone or other receiver. One of the key benefits is the ability for the patient to visualise their real-time blood glucose levels and respond accordingly. If desired, that data can also be shared with a healthcare professional to facilitate remote monitoring. There's also been some investigation into the use of artificial intelligence to identify high-risk periods and send automated messages to the patient. One of the key considerations is the cost of continuous blood glucose monitors, as they are comparatively more expensive to that finger prick traditional method. Patients may also have a varying degree of comfort with the idea of having something attached to their body all the time. I did want to show this graph from a paper by Adolphson et al. In the top graph, we can see the continuous blood glucose monitoring data. This line. The blue vertical bars indicate when the patient was having a meal, and this horizontal grey bar is the target glycemic range that we would like the patient to be in. In the bottom graph, we can see the data from the smart insulin pen, which shows doses administered as dots. This is an on-time dose because it was within the acceptable period for a meal, whereas this is a missed bolused dose, or MBD, and that's defined as the dose not being administered either 15 minutes before or up to 60 minutes after the start of a meal. In a similar manner to the chart that I showed earlier in my presentation, being able to display data something like this with various sources coming together can be incredibly helpful to see how they interrelate, and also for the healthcare professional to identify where they may need to adjust treatment, either with therapy changes or with education about how the patient should use their existing therapy. And finally, I wanted to briefly touch on artificial intelligence. I am by no means any sort of expert in this field, and certainly other speakers we've heard, such as Dr. Whitley Yee, spoke about it earlier on in the conference. But I did want to touch on a couple of things that are potentially of interest in the use of diabetes. Case-based reasoning is an AI technique to solve new problems based on learning from similar past encounters. It's being used to automatically detect problems in glucose control, propose solutions, and remember the effective and ineffective solutions for individual patients. It has been used to optimize insulin therapy for various meal situations for patients with diabetes. Machine learning has also been used to identify patients who are at high risk of developing diabetes based on genetic and metabolic factors. AI automated retinal screening was found to have a high rate of specificity and sensitivity at 93.7% and 92.3% respectively. But most interesting for me was an AI platform that was used for food recognition in nutrition management, which could correctly identify a meal based on a single photo with 87% accuracy. We already see people taking photos of their food to share on social media or to drool over when reminiscing about their favourite meals, but now there could actually be a third reason that people should take photos of their food. If we look to the future, I certainly expect continued expansion of the use of telehealth, thanks to COVID-19 nudging us to invest in equipment where it probably wasn't previously available, and also increased familiarity now for both patients and healthcare professionals, increasing accessibility of more health services, particularly for remote and regional settings, and those not able to easily leave their home is required. We can also anticipate an increase in the use of continuous blood glucose monitors as costs hopefully continue to fall and those devices become even more unobtrusive. There are certainly calls for improved regulation of smartphone apps and to standardise how they are reviewed and monitored for patient safety and clinical validity. As for artificial intelligence, things are changing so rapidly, I feel like I dare not venture a guess, but certainly I expect a lot of further investigation for where we can best put some of the benefits to use. And finally, if you're interested in any of what I've touched on today, you may like to read FIP's Advancements in Digital Pharmacy post-COVID-19 report, which has been published this year, and I've popped there. Thank you very much.
Well, thank you very much, Elise, in taking us into these new in the world of monitoring diabetes and getting better care in diabetes. And you have touched upon some points already on also applications and are they trustworthy and things. So, and wider section on how to use apps in the NCD this is where our next speaker comes in. Assistant Professor Mara Pereira, I'm going to say it anyway, Pereira Guerrero, but we'll call her Professor Santos. That's the easiest. And Professor Santos is a qualified pharmacist and has been a qualified pharmacist for over 10 years, and with experience in community pharmacy, and earned a PhD from the University of Manchester. Dr. Santos is an associate professor of the Igas Moniz School of Health and Science in Portugal and serves as a digital health and education catalyst within this organization. Her key competencies include funding, leadership, and management of research projects in digital health and education, and she has successfully led publicly funded national and international projects in this field. So further, she maintains connections with the digital business sector that might be, I don't know, did you have conflicts of interest? Yep, I think she had. Her contributions extend beyond project leadership in research and development. She has edited 4 books, co-authored over 15 book chapters and over 40 scientific papers, and made presentations in scientific events from plenary sessions by invitation to oral communications and workshops. She has supervised more than 40 students at a doctoral, master, and undergraduate level and guided them to obtain academic achievement and to refine skills and values. In her teaching, she has experience in implementing digitally enabled active learning methods such as team-based learning, flipped classrooms, project-based learning, and serious games. Her dedication to excellence has earned her the status of Fellow to the European Society of Clinical Pharmacy, as well as an international fellow status of the Faculty of Clinical Informatics in the UK. Her work has been honored with 7 awards and a merit-based scholarship. And throughout her career, she has lent her expertise to professional and governmental bodies, such as the Portuguese Pharmaceutical Society, a regional pharmacy and therapeutics committee, and the Portuguese Health Director General. And at an international level, she has served on governing bodies and of European scientific associations and acts as an evaluator of EU-funded science and technology program. So if you're in the EU, want funding, make sure that you're well known with Mara. And her personal values, including hard work, humility, and proactivity, humility, proactivity, commitment, integrity, and leading by example. And she wants to serve as a guiding compass in her professional endeavors. And I'm very glad that we have her to speak here. And please, may I give you the floor, Mara.
Right, thank you so much, Rob. And good morning, everyone. I'm delighted to be here and join the FIP conference. And I'll start, if I can operate, yes. Yes, I'll start by disclosing that I have an ongoing collaboration with the Australian company PainCheck, which is a company in digital health, in a research and innovation project. And I think now I'll move to the overview of my presentation, and I've divided my presentation into 3 parts. So first part, I'm going to give some examples of digital health technologies in pharmacy practice to manage NCDs. I will then move to talk about the value of these health technologies, and I will conclude by discussing challenges in the implementation. Okay, so let us start with the first part. And to give some examples of digital health technologies, I'm going to draw on an international classification. So some of you may be familiar with a classification that the WHO has for digital health interventions, and I think it's a really neat way of organizing what we're going to talk today. And the first level of this taxonomy or classification are the target so the recipients of the interventions. And here in the first, so in this slide, I'm going to talk about interventions that are targeting patients or clients. And then the second and third level is really about the purpose of the intervention. And if we can see, for example, the alerts and reminders. I guess that some of you here today in the audience, in community pharmacy or hospital pharmacy, may use a software that is able to send alerts to remind clients to take their medication, for example. So that's one example. And this could be done, by text messages. I think it's the most common way. Then, if we look to personal health tracking and specifically self-monitoring of health. And here I'm going to give an example that is from a project that we got funded about 5 years ago. In this project, we developed a prototype of a mobile app for older people with diabetes type 2. And the innovation really came in because the project core was to develop a virtual human coach. And it had really a strong basis of behavioral science. So the mobile app was supposed to support 3 target behaviors that are core in the self-management of diabetes type 2, so eating and physical activity and medication adherence. So the intervention included a wearable, so people would wear a pedometer. And here's an example of how sometimes you have a primary target group who are clients, and then you have a secondary target group. Because, for example, in this project, data from the mobile app would populate a dashboard, and it was behavioral data, basically. And the dashboard would be a tool for health professionals. So health professionals, if they had an in-person consultation with a person, for example, they could just look at the dashboard and discuss behavioral data. Okay, and let's now move to another level, which are interventions that target healthcare professionals. And we could have the client health records, and Elise already covered that, and in many other presentations in this conference we have heard examples. I brought 2 examples that I think are really nice. So my health record here in Australia, and my health record it has structured clinical records that can be accessed by community pharmacists to provide direct patient care. And another country that is really in the forefront, of course we have some other examples, but another country that is really in the forefront with sharing clinical data while using digital health technologies is the UK with the summary care records. And another example is clinical decision support. Again, I guess that many of you in the audience today will use a software that provides clinical decision support. And for us pharmacists, I think the most common alerts we get from our software systems are for drug-drug interactions and contraindications, for example, but you do have some softwares that will issue alerts or prompts for underprescribing, for example. So here's another example for pharmacy practice. And I'm now going to move to the second part of my presentation, and I'm going to talk about the value of digital health technologies. And when we discuss the value of digital health technologies, I think we often tend to focus on effectiveness. So if the technology does what it says it does, or what it's supposed to do. And I'm presenting this mapping of review studies by this research group, because I think it's really nice that in their work they have looked at other dimensions of value, and they draw on a concept of quality of care, and they summarized a couple of other dimensions that I think are really important when we think about the value of digital health technology. And these are, for example, patient safety and access to healthcare, and equity of care, and patient-centeredness. So let us look at data from this mapping of review studies. So first of all, this paper included 54 reviews, 13 scoping reviews, and the rest were systematic reviews with or without meta-analyses. And if we look at this graph here, we can see that, and this represents the number of reviews per category of quality of care. We can see that effectiveness is really an area that is well studied. So this is one end of the spectrum. On the other end of the spectrum, we would have aspects like patient-centeredness and equity of care, where less reviews have been published, and therefore we are led to believe that these are areas that require more research in terms of the value of digital health technologies. So in terms of effectiveness, because I think we pharmacists often, it's like our main concern, whether it works or not. So in terms of effectiveness and drawing on this mapping of reviews, I've developed this table, and you can see that the first column we have the examples, and examples that I'm citing here are reviews, are not primary studies. And then on the second column, you have the topic of the review. And you can see that in terms of conditions, we have really a lot of diversity. So we have obesity, we have stroke, hypertension, and anticoagulation, for example. And then between brackets, you have how the technology is delivered. Because of course it can be delivered in many ways, shapes and forms, and Elise showed that already. We could have mobile apps, which are by far one of the most common forms of technology that we use in digital health. And then, of course, you could have text messages, and you could have telemedicine, etc. So what Elise just showed. And then if we look at how effective are the interventions based on the review studies, we can see that with the exception of anticoagulation and CV diseases, we actually have positive results, and particularly in terms of behaviors. Because, as it has been touched upon by other speakers, many of the things we're trying to change with digital health technology for customers, so for clients or patients, are behaviors. And if you think of NCDs, a lot of self-management is based on changing behaviors. So it is good that we are getting positive results on this front. Also, on treatment compliance, as it was designated by the authors of this work, we also have good results in some cases, and it shows promise. Right, so I'm now going to move to the last part of my presentation, and I'm going to discuss the challenges in the implementation of digital health technologies to manage NCDs. And I think we often think that if a digital technology works, so for example, if a mobile app has shown effectiveness in improving some clinical endpoints, then it's certainly going to be adopted in routine practice. And unfortunately, it's not that simple. And actually, well, implementation of any technology that is innovative, so it's new, in routine practice, it's quite complex. And we have to think about, well, we have to think about the system and not about the technology only, and how complex and dynamic the system is. And this is why I like to use implementation frameworks to discuss implementation, because implementation frameworks are so helpful to, well, to guide us to reflect on certain aspects that otherwise we wouldn't be thinking of. And I'm presenting the NAS framework. We certainly have other implementation frameworks, but I like the NAS framework because it's specific for digital innovation. So it has many aspects that are specific. And it was developed by Greenhalgh and colleagues from the University of Oxford in the UK, while using a very sound process. And they looked at data at micro level, at meso level, and at micro level, at meso level, and macro level. And this is where the systems part that I was telling you about comes in. It's good that we take this wide approach. And I know the figure is probably not very informative because the font is too small, but we're going to see some of the examples. But the figure is just to illustrate that the NAS framework is comprised by 7 domains. And each domain has a number of items. And for each item, and it should not be used as a checklist. It should be used as a reflection tool. And for each item, you reflect on whether implementation is simple, is complicated, or it's complex. And the authors provide some operational definitions to help you. Okay, so let us look now at the 7 domains of the NAS framework and give some examples. I won't go into detail because I don't have the time, but for example, if you think of the value proposition is really about whether the technology is worth being adopted. And the adopter system, I think we often fail to consider the adopter system. And if the technology is a threat to the identity of pharmacists, for example, we have a huge barrier for implementation. If, on the opposite, the technology is perceived by pharmacists as supporting them in their role, so it would be a facilitator. Of course, it's not to say that a technology that is perceived as a threat to the professional role, it will never be implemented. It's just that we need to consider this aspect in the development process. Other domains are, for example, the organization. It's completely different if you want a technology to be implemented. It's completely different if you have a care pathway or if there is no care pathway. So two cases that if there is a care pathway, the technology that we are introducing should flow with a care pathway. If not, we have to create a care pathway, and that's different in terms of implementation. And the wider context, as we are going to see, the wider context is hugely influential. We're going to see that in some countries, and perhaps you have that experience in some of your countries. In some countries, apps are being reimbursed. So they are provided to patients at no cost, for example. And this, of course, it's a huge facilitator. Okay. So I'm now going to try to have a bit of interaction with the audience because this is the point where you probably are falling asleep. So I'm going to throw a question and I'll ask for a show of hands. How many of you in the audience feel confident to recommend apps for the management of NCDs? And can I have a show of hands? I'm having some cards also. Okay. Right. Okay, thank you very much. Right, I'm going back. Let me see if I can go back in the slide. Okay, so I haven't seen many people saying, yes, we're confident to recommend apps for the management of NCDs. And I completely understand that, and we're going to see why. First of all, apps are very common. As I explained, and I think we all have this notion, apps are probably the most common form of digital health technology nowadays. And if you look at the market, you have under 400,000 apps on the market. And every day, at a global scale, you have 5 million downloads. So this is huge. The problem is really the quality of the apps. And if you look at this big circle here, and this is from an overview of systematic reviews that was published in 2018. If you look at this big circle here, it represents all available mHealth apps in app stores, right? And then if you look at this tiny portion here, it represents the apps that were tested via an RCT. So it means, and as you can see, it's a minority. So it means that you have many apps out there on the market that were not tested to show whether they work or not. And in some cases, it's not the fact that it was not an RCT. In some cases, they weren't simply tested. And of course, this poses huge concerns in terms of quality. But not only that, because when we think of quality, we have a number of dimensions, and of course effectiveness is one of the dimensions, but we have to look at other aspects also. So usability, for example, so if the user has a good experience. The quality of the content you have in there, if it has information. And technical features. I think technical features such as privacy and security are becoming increasingly important nowadays because, of course, all these apps are collecting huge amounts of data, and we have to be clear about who owns the data, how is the data being used, etc. And also to protect the data from leaks. So these aspects are, I would say, well, very important when we think about quality. How can we overcome this quality problem that we have with many of the apps that are out there on the market? We have two routes, really, and one route is looking at assessment frameworks. So having the apps assessed using a framework that is transparent. And we have a couple of examples internationally, and this is by no means exhaustive. But in the UK, Orca, have you heard of Orca? Yes, we have one person. I've heard of Orca. Okay, so Orca is a private company. It's based in the UK, and it started a couple of years ago with assessment. So it assesses apps, and nowadays it's a paid service, so it's a subscription service, but it provides this service to health professionals and to health services also. And if you have the app assessed using well, the criteria that Orca has, it gives you, and of course if it scores well, it gives you a seal of quality. You also have other assessment frameworks in countries such as the UK and the USA. And of course, if we as health professionals see an app that has undergone this assessment process, and if it did well, I think then we can be confident to recommend that app. And another route that is being taken by some countries is not only the assessment route, but also the possibility of prescribing apps and reimbursing the apps. So in the same way as you reimburse medicines, some countries are taking the route of reimbursing apps that are for clients. Well, Germany really pioneered this movement when in 2019 it passed the Digital Healthcare Act. And as per February this year, you had over 40 apps that are part of this system. Some are conditional, so it means that the numbers could reduce at some point in time and not necessarily increase. But you have over 40 apps that can be prescribed. And France and other countries in Europe actually, and the US the same, are taking this route. So of course, this provides a confidence that is very much needed to health professionals that the app has quality. Now, I'm now going to throw a provocative question. Do you think pharmacists are ready to prescribe apps to support the management of NCDs? And can I have a show of hands? Okay, so not many people are saying yes. And I'm being provocative here, and I think in the roundtable discussion we can, if it interests you, we can resume this discussion because, for example, in Germany, only physicians currently are allowed to prescribe apps. And we should bear in mind that many of these apps focus on behaviors, on self-care behaviors. So I think we have space here to debate whether these should be restricted to physicians only. Right, so for those of you who don't feel very confident to prescribe apps, I'm not sure if one of the reasons is digital health competence. But a report was launched by FIP, and this report was a global study on digital health in pharmacy education. And this report showed that a large proportion of schools of pharmacy don't offer any curricula on this. And unsurprisingly, the report, and I'm quoting a paper here, but you have a report which is Lancier. Well, the report showed that there are gaps in the skill sets and knowledge of future pharmacies to apply digital health technologies to solve clinical problems and to improve care. So I think this is one of the aspects. Of course, as we've seen, implementation is quite complex, and it's not only to the individual, but at the same time, if the individual does not have the capacity or feels that he or she does not have the capacity, implementation is going to be really difficult. So for all of us as educators in pharmacy, I think there is food for thought here. Okay, and I'm reaching the end of my presentation, and my last question is, I guess that some of you are practicing pharmacists. If you think that persons living with NCDs are prepared to engage with digital health technology. Okay. I like this audience, it's very mixed. which just keeps me going. Okay, so it was mixed once again, and yes, I think as Elise showed, we have a number of barriers here, and when we talk about digital health technology, the issue of excluding certain groups is really a concern. And in this table, in a very short form, I try to summarize some groups that we have really to pay attention to because they could be excluded from digital health technologies. And as we've seen, some countries are really moving at a very fast pace towards a system that is very digital. So we have really to think carefully of not leaving anyone behind. And as Elise talked, low-income and deprived groups are one of the groups that we should be talking about. Of course, smartphones, I think, well, the data, of course, you have different sources, but if you look at smartphone ownership or possession, it's actually quite high, even in low-income groups. Now, another aspect is access to the internet, for example, because that could be a problem, and digital competence, so the competence to use apps that have a purpose of preventing or managing disease. Another group we should be thinking of are ethnic minorities, because here you have a barrier that is about the appropriateness of content for these groups and the language. And one of the recipes, I guess, I'm a strong advocate for co-creation. And I think, so co-creation, when you involve end users, from coming up with a solution and then producing the solution and then assessing the solution, I think co-creation is quite a powerful mechanism for mitigating at least some of these divides we may have. And of course, for people with disabilities is the same thing. And disabilities, it could be something that we all have in a couple of years, I guess, like or could have, like difficulties moving your fingers and impaired vision. So we really should think of evolving these people, and particularly if they are part of the target group, of course, so that we leave no one behind. And I've reached the end of my presentation, so just a few key messages. So in pharmacy practice, when we think about digital health technologies for NCDs management, we've seen that they can be delivered in various forms, and they can target clients or healthcare professionals or both. And mobile apps are actually among the most common technologies. Secondly, as a key message, we've seen that effectiveness is the dimension of a value that is supported by more evidence, and equity and patient-centeredness have received less attention. And finally, a third message, when we think of challenges to implementation, the quality of mobile apps is really a concern. The digital health competence of pharmacists and other healthcare professionals is or could be another barrier. And the risk of exclusion of certain groups is also a barrier that we have to take into consideration. Now, if we think of these challenges in the development process, I think we could perhaps mitigate, them and smooth implementation. So thank you very much for listening. If you want to reach out, you have here my email, and of course LinkedIn works very well for me. So thanks for listening.
Well, thank you very, very much, Professor Sanders. It was very interesting to see the broader picture also, and of acceptance of apps and regulations going on and the things. We will have a question and answer session now. Are there any questions from the audience at this point? Yes, please.
Thank you very much to both speakers, Martin Hemman from Ireland. I thought one of the things that seemed to be missing, and it was present on one of Mara's slides there, was the contribution that this might make to coordination and continuity of care. Because it seems to be very much focused on individuals to whom it maybe can be sold or whatever, or prescribed for individuals, but it's not linking care together very well. And that always seems to me to be a difficulty. Could you comment?
Either. I completely agree. I think there's so much data sitting out there in separate silos, and the value of that is so high, but it's not being well utilised by all the different healthcare professionals in the system. And I don't think either our mindset, our technology, various factors are very well set up at the moment to make best use of that. It's not standard practice for the patient comes in for their repeat dispensing of insulin, and the pharmacist says, can I upload your smart app data to see how your blood glucose has been going? Have you got a smart insulin pen? Let's just have a check and see if you're having any challenges with being able to administer doses on time, and having a chat about that. It's not part of our standard practice currently, and it would be wonderful to get to that point, but it's going to take multiple factors, including the drive from us as pharmacists to want that data and realise the value of it, I think, at the moment. But it's my 2 cents. Do you have 5 cents to offer?
Right. Thanks, Elise, and thanks, Martin, for the question. Now, I think we have a huge potential here, and also a couple of barriers. So I think the potential is, as you said, to unite information, because So as a community pharmacist, when I practice, I had my own data, so local data, but I had no idea of data from other settings. And I think in many countries, we still practice like that. But I think it's changing, and it's changing at a fast pace, and I think the case of Australia and the UK, for example, it shows that. Now, in Portugal, if I can give my own country as an example, the problem we are facing now is not lack of political will, because in some instances there is lack of political will to grant access to community pharmacies, for example, to clinical data. I think in Portugal, the problem we're facing now is that systems don't talk to each other. So interoperability. And this is a huge, huge challenge because you have loads of systems. So each hospital is equipped with one system and community pharmacies have their system, etc. And the barrier I see now, I don't think is any more lack of political will, is really an IT barrier. So yes, I think it could, answering your question more directly, I think it holds a lot of promise. And provided we can overcome this interoperability barrier. I hope I have addressed your question.
If I may just allude on that slightly. One of the things, we were talking about advanced systems. We're in advanced high-income country systems where we're talking about implementation this within systems. Do you see for the low and middle income countries, is this a real, like an opportunity, or is it a threat because it is too expensive? And of course, how could they best use these technologies? Is it sensible to go leapfrog? We have the interoperability problems. That's actually a legacy. That's a problem in high income countries, which they don't have in low and middle income countries yet. And will these technologies leapfrog healthcare?
I hope that by some of the challenges being worked through in higher income countries, like that cost of the continuous blood glucose monitoring, as they become more widespread, as the manufacturers work out how to develop them more efficiently, that cost will come down, that then may make it more accessible, I suppose, to some areas that don't have as much funding. But yeah, look, it's a really tricky thing to work through.
Are there any questions? More? Yes, please. Yeah.
Hi, Karen Castle from Australia. I have two questions. I really liked the diagram, the Venn diagram that showed the sweet spot where there was some apps that have been part of a randomised control trial and also in a systematic review. Can you give us any examples of apps that do fall into that sweet spot? And for anyone on the stage, if you have any favourite healthcare apps, current or under development, that you can share.
Right, so if I understood your question, is if I can give examples of apps that have been submitted to randomized controlled trials, that have been tested by randomized controlled trials. Was that the question? Yes. Okay, you see, I'm terrible with names, and because I don't use some of these apps, I may struggle. But there is, I can perhaps talk to you after and give you a couple of papers that give examples. So at least some of the apps that are being reimbursed in Germany, many of them have been subjected to RCTs, right? Now, I haven't had any experience with PainCheck, which is part of the work I'm doing now, but I think Jeff is on the audience. Yeah, well, Jeff, if perhaps you can share the experience of PainCheck, well, not necessarily with RCTs, but if you can share the experience, would that be appropriate?
Yes, so with PainCheck, we haven't done any RTCs because we've done non-interventional observational studies, and pain check is assessing pain in people who cannot self-report their pain, so people who've got dementia. So in Australia we used Abbey Pain Scale as our comparator. We repeated those studies in the UK, so it's the first digital app, pain assessment app that's been regulatory cleared, and at the moment we're just starting a study in the US to do the same. So we've done work related to the accuracy, reliability, validity of the app, and to move into Germany and those places, then we need to do outcome work in that particular space. So there are a lot of work, particularly if you read the Journal of Medicine and Internet Research, a lot of work on apps around cognitive behavioural therapy and impact on a whole range of different diseases in that space. There are a lot of RTCs in there.
Does that
Sorry,
answer
Rob,
your...
if I may, just one question.
Sure.
Well, it's not a question, it's a comment. I think with some particular populations, like people with dementia, an RCT poses enormous problems. And you start with, of course, with consent and the vulnerability of these people. So sometimes an RCT, of course, it's like the RCT is the ideal design, but in some circumstances, it could be that it's not appropriate. But some form of assessment and testing, etc., it's absolutely essential, as Jeff explained.
You'll be better placed to correct my memory if I'm misremembering, but I think in that FIP document that I had on the very last slide about the updates to digital health since COVID-19, that also talks about the need and the fact that we are getting to a point where there's sort of a list of, here are some good apps available. It's got a much fancier name, but so that might be an interesting resource to just have a look at as well if you haven't already. Is there anything you want to...
Very good. No, thank you very much for reminding. Any more questions here from the audience? And please let me ask you, we see these abundance of apps, and that is clinical trials. They're either really well, certified or not certified. But what is the role of pharmacists in getting into the system? Because indeed, it is part, as was mentioned, part of a health system. And what role do you think pharmacists should really play? Should they go also to be sort of the spider in the web and getting all healthcare workers together in getting things available, or is it, should we wait until the patients come along and sort of say, we're all using this? And what is the role that the pharmacist can really play in that? And of course, do we have enough knowledge of education? Are our skills well enough for that? Could you?
I think as pharmacists, if we are practicing in a country where apps are being reimbursed, that's fantastic, because even if at that point we can't prescribe them, like in Germany, at least we know that, well, those apps are good, right? So that's a first step. I share the concerns that the audience has about recommending apps that haven't received a seal of approval. Well, just because I think even for me as a researcher working in this area for over almost 10 years, it's difficult to assess certain aspects. And as a community pharmacist, I wouldn't really have the time for that. So I think some form of external assessment is super important. And of course, it should be for an app that is available in the language of your country, for example, because I don't think in Portugal, for many patients, an app in English does the job, right? So of course, you have, these kind of details. But in many countries, although you don't have yet assessment criteria, you sometimes have lists of apps that have been reviewed by scientific societies or certain patients groups, for example. And that could be a start if you don't have assessment criteria that are explicit and nationwide, for example. I'm not sure if I addressed your question.
No, certainly.
I think there's also a role for our professional societies here to facilitate getting that knowledge out to all of the different practitioners who might be searching for it or have had patients ask about it but feeling a bit uncomfortable, noting that improving our university education is great, but there's an awful lot of us who are out in the field and practicing at the moment. And so taking on some responsibility to say this is obviously an area that we anticipate continuing to grow, and putting some of the pieces of the puzzle together to help their members, I think would be a really valuable role that professional societies could take on.
Yeah, Rob, if I may. I just think about the prescribing of apps. I'm seeing a missed opportunity here, because it really surprised me that in Germany nowadays, apps are only being prescribed by physicians. And all the work that we have done in the last years, just using behavioral science and applying that to digital health, I think we as pharmacists are ideally positioned to support patients in self-care behaviors. And I can't understand, I don't see a reason why we are being excluded of this process. So I think FIP perhaps, of course, FIP has the advisory boards and all that, could take this on board and raise awareness for the fact that we are part of the solution. And if we can prescribe apps, I think we can add value. So I think it is as if we're starting to see something in the beginning and we're not part of it, and it really surprises me.
And I think there's also a bit of a, what's the word I want, feedback loop sort of thing, that if we start to increase our role in that sphere, app developers can see that, these people are recommending this specific app. I want my app to be, the one who's out there and most commonly used. I better tick all of these boxes of interoperability, user-friendly, equality, let alone effectiveness. And so hopefully, in my optimistic manner, that delightful thing ends up that we end up with a lot of high-quality apps for lots of different conditions that we could then be recommending to our patients and have them merrily fit in with our dispensing software or our electronic health records or our GP software, wherever we may be practicing to make the best use of them. That is my rosy-coloured glasses view.
Savvy pharmacists are always optimistic people. That's the one thing that I find. Please.
Hello.
Can we have the mic there?
Okay.
Oh, sorry. I think we have the mic there. Sorry.
Oh.
All right.
Sorry
Thank
about
you.
that.
Thank you. Just a quick one. With all this innovation and technologies that is coming up, it's making life easy. But sorry, my name is Geoffrey from Tanzania. So I was just wondering, with what you have just commented there, your experience in Portugal, that the systems are not interlinked, so we are missing quite a lot. Is there something that we should think of as pharmacists? Because I think there might be dangers of us missing quite a lot of information, patient information, for us to make informed decision to help this patient with all this technology and apps which are not linked. What could possibly be done to make sure that in near future maybe the informations and all the apps and the innovations are interlinked in a way that they can help us to make better decisions to help these patients?
Wow.
Okay, thanks for the question. Very interesting, and that's the $1 million question, really. I think one thing is technical capability, and that has to be addressed by developers. And the other thing is patient consent, because although for us, ideally, as professionals, all the data would populate a system and we have access to that system because we are providing care, I think patient consent is really a key thing that we have to consider because, well, some patients may not want that his or her data is shared. So I'm not sure if I have addressed your question, but these are my thoughts.
The comment there?
Yes, a comment leading on from what you were saying before. Andrew Petrie from Brisbane. It seems to me that it's, from what we've seen, relatively early implementation of the technology in certainly this country, and I suspect many others. And it seems that the one approach to the issue of pharmacists not being able to prescribe is to jump in early in the stage through the professional organisations to work together interprofessionally, to work together with the other groups who are likely to be able to prescribe so that together they develop a model where pharmacists will be involved and where there's the broad consideration given. Have you got a comment on that approach?
I completely agree. I think it's not up to us individuals. I think individually we have to be able and competent to do things, but I think it's very difficult if professional bodies are not involved. It's going to be very difficult. So I would say that the task now is to raise awareness in professional bodies about this, because I just feel that it is as if you're seeing a bus passing and you miss it. So raising awareness in professional bodies, I think, is the key thing now, and I completely agree with your comment.
And I think looking at what's out there, looking at some of the apps that have that evidence, and trying to pick your targets as a bit of a staged approach might make it more manageable. So if we say that diabetes is affecting a significant proportion of the population and has lots of reasons why it would be a good target, that might be a good place to start, rather than trying to feel that, okay, which app are we going to recommend for all these different conditions, to get us feeling comfortable with the concept of an interdisciplinary relationship with this app and the patient at the centre of it all, because otherwise it, I think, is fairly daunting to try and tackle everything at once.
Yes, please.
So Jeff Hughes from Australia. I just want to make two comments. One around apps which are prescribed. So, for example, an FDA, if I am going to go through that process, then I have to define the end user. And I can define the end user as a medical professional, a pharmacist, etc. And so we need to lift the profile of pharmacists with app developers in order to put part of the study that goes through has pharmacists as prescribers. So that's an important part. I think the other thing is that when you've got doctors prescribers, they've got a much knowledge of technology as pharmacists. All right, so the people who are into technology are going to use it to their advantage. And those who are not will put their heads in the sand and not adopt it. But if you look at it from the perspective of, I want to be a diabetic pharmacy, and I want to be a wound pharmacy, if I focus and look at those particular technologies, and I look at the reviews and get patient buy-in in those particular areas, then I can improve care, I can get more people coming back to see me, I get better compliance and get all those particular outcomes from it. So I think the implementation strategies that Mara was alluding to, we need to think about how do we implement technology into community pharmacy, and that's a completely different thing. But if you look about pharmacists, we got electronic dispensing. We took it on board and we've done a lot with that. There's more we can do. So, comments from the front?
I think bigger than that too, that same data, I'd also want it to be taken to my outpatient appointment with my pre-admission clinic pharmacist and then my anaesthetist, and then, during my stay in the hospital setting, my GP pharmacist and my GP. There is so much potential there if we can have a group engaged in getting patients on board with using this. It can then benefit a lot of the healthcare system. So yes, that'd be great if we could just make that happen overnight. That would be wonderful, but a wonderful thing to work towards.
I agree, Jeff, with your comment. I think implementation, it's about system really, so you have the individual level and the wider context, right? And we've seen situations where certain technologies are not even digital, well, they are reimbursed, but they are not uptaken, right? So you have no adoption. So yes, so merely the reimbursement or the ability for pharmacies to prescribe an app, it doesn't mean it will be implemented. And clearly we need, as I see it, and also informed by implementation frameworks, we need to look at several aspects. So the individual aspect, as you said, so making sure that people are able and so they have the capacity and the motivation to do it. And then, like, the wider context.
I'm slightly, as a chair, I'm slightly conscious of the time, so I think we should be wrapping up the session. It's a pity because for me, the session is really my mind spinning about things going on and that we could be doing as pharmacists. But I want to thank both speakers very much for their insightful presentations, and it really helped me personally in understanding the use of apps in NCDs more. I wish we had more time to have the discussion, but this is the limitation of a conference. It's limited in time, and I'm sure other people have to go to other sessions too. But please join me to thank Dr. Santos and Elise, I'm sorry, I'm doing it in that way, for the presentations, and thank you very much for coming here.